So we're here today on a live podcast to really see if anybody's interested in being engaged and talk about our annual meeting. It's coming up in 2 weeks. We plan to do 2 live podcasts this week and next week, and really kind of get a sense of what to look forward to at annual meeting in Orlando. And I know we've been intentional at ASCP about the broad variety of members that we have. I think if we think about the beginning of this podcast, we went through history and we talked to some of the early people that were members of ASCP, and we're there at some of the formative stages of long-term care pharmacy where it, really came into its own. And the reality is ASCP is a membership organization of pharmacists that at certain times and currently are owners of pharmacies that distribute medications in long-term care settings like skilled nursing and assisted living. They're also pharmacists that work in clinical situations with patients in nursing homes and assisted living and in the community. And like any industry, it's grown. And it's grown with a group of individuals, generally older adult individuals, that now represent a major percentage of the U.S. population. Yeah. And what really began as a community drugstore figuring out how to deliver meds into a newly developed at the time nursing home has turned into an entire industry that has really moved on 2 planes. One, logistics, storage, handling, delivery, packaging, managing medications from that aspect, and how do you clinically deal with people that are on 8, 10, 12 medications, drug interactions, regulations that are oversee people in nursing homes, the good and the bad of all of that. Yeah. So,
and you see that the evolution of United States healthcare in general, because back in the 1950s, patients or residents were starting to create these nursing homes, and there was starting to be a specific need. And ASCP, back in its founding days, stepped up and said, these patients are different. We got to do things differently. We can't just dispense drugs. There's all these other areas of clinical needs that they have. Now we're seeing it actually kind of reverting and going back the opposite, only because the baby boomer population is growing so dramatically, so quick. It's supposed to be a 50% growth over the next 5-6 years. They're not keeping up on building nursing homes and having this one institutionalized settings. Now it's saying, hey, these patients are still sick. They still have multiple ADLs. They still have needs, critical needs. But now instead of being at one place, they're going to be spread out all over. So how do long-term care pharmacies bring their service, their expertise, their care to that senior population, but in individual basis throughout the U.S.? And that's the challenge that we're facing.
Yeah, and I think, when you're in this space, I don't. Even if you're not even a pharmacist, you get questions a lot because we all have parents, we all have grandparents, we all know friends and family that are getting older, and they have questions about medications, and they want answers. They want conveniences. They want to know how they're going to get through a condition or deal with a therapy that they've been prescribed. And there's just no way out for the U.S. healthcare system other than through medication management. And at the core of medication management is generally a pharmacist.
Yeah, and that's the least expensive way to do it, really.
Yeah. Well, and the system sort of... there clearly is no master plan. The government does not have a master plan, but they have not invested in skilled nursing facilities in the last 25 years. And by investment, I mean, not are they paying, for the services. I mean, they've not allocated any new nursing home licensed beds. Like, we have the same number that we've had for 25 years. If you do that in an environment with a rapidly aging population, you're changing the dynamic of that nursing home. It is no longer the rest home in 1969.
It's a step-down unit.
Yeah, it's a rehabilitation center, and you keep shifting people into nursing homes that are becoming more comorbid, more acute. Mm-hmm. Some of them are transitioning on their way out of the hospital back to home. Some of them are so comorbid or advanced that they have to be in a nursing home setting. But without expanding that you've seen the growth of assisted living kind of pop up to pick up some of the slack that nursing homes can't take care of anymore. That's unfortunately or fortunately, depending on how you look at it, it's a hospitality model. So it's a model for people that are more affluent because you have to pay to be there. There's a few states with waivers where people on Medicaid can end up in an assisted living facility, but that exists. And then there's different PACE models that attempt to take care of older adults in community settings differently. And then there's your home setting.
Yeah.
And the reality is everybody's getting more people. We're getting more, the nursing home of tomorrow is going to be advanced people. The very worst of those suffering from Alzheimer's, from psychosis, the most in need of rehabilitation services are going to cycle through. There'll be growth in that industry in the sense that they need more resources.
Right.
So in other words, pharmacy costs will go up because the people coming in are the forgive the term, train wreck individual that can't go back home or can't ever go back home.
And if you're a business owner, if you're an investor, if you're an entrepreneur, do you really want to invest into nursing homes? They're one of the most highly regulated industries in America, and there's good reasons for a lot of those regulations, but it's also, I guess, more than challenging. It's almost overwhelming as far as the regulation goes. And then the payors, the people that are writing the checks, they're like, I'm not going to pay for that nursing home. I'd rather, if I have that insurance decision, I'm going to decide as a business owner of the insurance or whatever, the provider, to keep them at home. And so here we're kind of getting hit from all different edges. But the result is these patients are going to be at home, but they're going to have long-term care needs, and they're going to need long-term care help. And they're going to need long-term care oversight and long-term care expertise.
Yeah, and even within that group, there's going to be tiers of individuals. There are going to be people that might need services on the low end of acuity, and there are going to be people that need services on the high end of acuity, not as high as needing to be in a nursing home, but at the high end of the group that wants to be at home and be cared for at home. So it's going to take all of the acumen that this industry has built over the last 54 years to deal with that.
Right.
There's going to be different models. There's going to be service levels, and we have to adapt into that. And what's funny about pharmacy is that it ends up being, maybe because this is the industry I'm in, but in this long-term care space, it's sort of the convergence of all the things we as pharmacists want to be part of. There's a consulting component to it. I want to look at your medications and give you advice and work with your physicians and nurse practitioners on how to make it the best therapy for you. There's I want to deliver to you, packaging that makes it easy for you to live your life, that you can peel a packet off in the morning when you go golf because you have a noon meds. All of those aspects are kind of building back into one, where the pharmacy is sort of that central location for patients living at home that gives them freedom. Right. It allows them to live their lives the way they want to live their lives.
So one of the hurdles, if you're a long-term care pharmacy, you understand that. We're not telling you anything you probably don't know about where the industry's going. But one of those hurdles is, man, I'm getting maybe a third less reimbursement for that patient when they're same conditions and same disease states, but they're residing here in this home or in their personal home versus residing in this nursing home. And I'm doing everything the same. It's like I'm delivering the car, the service, the product. I bet it's happened delivered here instead of there, but I'm getting paid a third less.
Yep.
And so they're like, I'd rather not, I'd rather kind of avoid that. Oh yeah, by the way, it's more difficult to deliver there because there's 1,000 different drop locations instead of one that I'm going to have to do. So what's your thoughts or I guess concerns on that, and where do you think that we need to head?
I think it's again, it's sort of the history of pharmacy. We have pharmacies out there that have invested in what we would loosely call long-term care at home. Like we're gonna provide services to people at home that are more advanced. We're gonna use new technologies. We're gonna have them talk to a pharmacist on a periodic basis. We're going to package it in the way that we want to package it. We're going to try to work with the payers to get reimbursed fairly for that. And in some pockets, they're getting different reimbursement to support that. In other pockets, to your point, they're not. They're trying to figure out, how do I do it getting paid a third less? And some of them have never worked in the long-term care space, so a third less isn't their perspective.
They're used to that.
They're just used to what it is. And how can I do enough volume at this long-term care at home to make my business work? But we have to have that, because we can't sit around and go, hey, government, you should pay for these enhanced services for these people at home because they're just as sick and ill as the people 10 years ago that were in the nursing home getting all these services, because you'll be waiting a long time for that. And you have to be able to prove, hey, there are people out there that are either paying cash, or there are a couple small insurance companies that have decided to invest in this. It's working. Government, you need to make sure that everybody has access to that kind of service, not just, people in certain areas, or maybe not just people that have money and can afford it. You're disenfranchising a group that now is forced to live at home. They can't manage, but they have no access to services that they need. So that's the game that you play with the government.
Yeah, no, for sure. And I think pharmacies have to start realizing, or looking into and investigating areas that same patient has more needs than just the prescription drugs. And, we can talk about how to expand, their vitamins, their over-the-counters, and all these different stuff. I mean, if the patient's at home, they're getting those items, those medical supplies and that stuff from somewhere, from Amazon, Walmart, somewhere. They're getting those items. You're already delivering their medications, but you're also their trusted pharmacy. And then be able to provide all their other needs. And again, typically long-term care pharmacies don't think that way. I think retail pharmacies do. And so for pharmacists to start thinking, well, okay, there's more products than just the prescription drug. And now I've expanded and grown. I increased the monies per patient, or per transaction, per person. In addition to that, we start talking about clinical billing. We start talking about remote patient monitoring and all these other different ways where I can now generate even provider type of money that's not subject to PBM restrictions, and really look at that patient as holistic. That patient has so many different needs that I, as a professional healthcare provider, can provide to, can generate revenue from, without just sitting here going, well, I'm just not getting paid as much for my drugs.
Yeah. And, to pull that all the way back to Orlando in 2 weeks with the ASCP meeting, the whole point, we deliver deep clinical information. You want to learn about the best ways to care for somebody that has diabetes, that'll be there. We're going to have regulatory information. You want to learn what the latest changes are to the MDS or to the F-tags, that'll be there. But there's these other two components, these almost how-to components. Mm-hmm. How do you service, or how do you approach an at-home group? How do you better improve the operations of your pharmacy? How do you squeeze more juice out of the lemon? How do you bill for some of these? I've always said, I think provider status for pharmacists is death by 1,000 cuts. Mm-hmm. There's MTM. There's getting paid to administer a vaccine. There is incident to billing. There are comprehensive medication reviews. There's an array of things.
Right.
Now, it's super complicated. You kind of have to figure it out, learn it, and then apply it. Yeah. And you might not do all those things. You might do some of those things. But it's starting to get to the point where you can build a viable reimbursement structure for a pharmacist that are doing those kinds of activities. Right. Whereas before it was, you get paid a little for that, but you have to still be doing the pharmacy work, you have to be doing something else, and this just adds on. It's starting to sort of coalesce into something potentially meaningful, but it does take that how-to.
Yeah.
And I think what we're trying to deliver in our meetings, both at the annual meeting and through our regional meetings, is how do I do this? How do I bill incident to? How do I set up a vaccine clinic? How do I improve my operations in the variety of ways that we have experts coming in to talk about it? And that's what we need to be thinking about.
Those are here, those are now, those are today.
Right, they're real.
We both know pharmacists that are doing that are mm-hmm. successful at it. Just talked to a pharmacist the other day that he did a vaccination clinic, and they had something around 2,000 people show up. and you're talking $150 a pop.
Yeah.
And they probably had 2 or 3 pharmacists there. So whatever that cost was, those pharmacists, but do the math. And it was a great, I mean, he was excited. It was a great revenue producing area, but also what it told the entire community is we're here. Mm-hmm. Yeah, you might have not known us because we were a nursing home, but hey, we're here. I've got a friend who lives in England, and he works with pharmacies in England and helps them with build outs and design and that kind of stuff. And he was telling me, he goes, the U.S.'s pharmacies, the way they think is so far behind England. And I said, yeah, but we got better hygiene. We do a lot of things better.
Better teeth? Can we say that?
Yeah,
anyway.
We can. But what he was saying is our community pharmacies, they started our community pharmacies, and it's a one-payer system, so I understand things are different. But he said they don't sit there and just hope that more traffic comes in. They create traffic. They'll take their actual pharmacies, they'll build out specific rooms, like a holistic room, massage therapy, dental practice, eye doctor, whatever it is.
Kind of medical mall.
Yeah, a medical mall. Kind of we saw, Walmart trying to do, But what they do is they attract those patients saying, hey, you can come here to our pharmacy, visit your infusion therapist or whatever it is, and they tie the over-the-counters and they tie their sales and everything directly to that. They charge that clinician or that doctor for that space, and that doctor might rotate to 2 or 3 pharmacies, in London or whatever it is. But my point is that they're adapting, they're creating revenue streams. They're trying to diversify, and that wasn't maybe their main thing, but that's healthcare related. The community already trusted that pharmacy, might as well go in and do this as well. And so they're trying to just evolve as fast as they can.
Yeah, and I think when we think of, I like the USA Boxing grant example because it's so left field, but not left field. Like it evolved from a health policy meeting on vaccinations that pharmacists were giving in long-term care. And it just so happened that a individual that worked for a healthcare advocacy firm also represented USA Boxing and came up to us and said, what you guys are doing in long-term care is great stuff. It seems like you know how to run into an assisted living center and do a vaccine clinic. That doesn't mean that community pharmacies haven't been doing that. They've done that. But they were enamored by this long-term care pharmacy aspect. And it spawned, hey, will you connect your pharmacies to our events to do these clinics? And it comes at a time when, vaccines is a viable revenue stream. Like pharmacies should be invested in that. You're getting the revenue from the product, the spread on the product based on what you're able to buy it for. You're getting the administration fee, which have improved dramatically since COVID. I mean, $40 a shot for a COVID shot that's a lot. I mean, let's say you get $20 spread on the vaccine. That's $60 a shot. Let's say you're going into a AL building of 100 people. That's good revenue. Yep. But the point is that it's coming at the same time as we're sort of pushing out into the community. And if there's one thing I can for certain say, because we used to say it when I worked in long-term care pharmacy, is that we loved being in the industrial park. We loved, some states said, if you're a pharmacy, you have to put pharmacy on the door. And we would minimize that because you didn't want people to know that we had a stockpile of narcotics in this building.
And we weren't here in the middle of the night.
Right. And you're in an industrial park. Yeah. Like, it's not like you're going to get a lot of foot traffic around there that provide any sense of security. Yeah. Mm-hmm. So, but now we need the public to understand who is Pharmerica, who is, Remedy, who are these pharmacies that are servicing these assisted living centers and these nursing homes. I might know them because my dad is in one of those facilities, but in general,
they don't advertise.
Yeah, they don't advertise
because we don't have to the public.
So combining the opportunity for vaccine, doing it at sporting events like boxing, judo, fencing, curling, whatever it is in the area, all of a sudden presents the name of the pharmacy in a direct way that the public can recognize. Right. Guardian Pharmacy's in here doing vaccines at this boxing event. That's awesome.
Yeah.
So, and it sets the stage for, Guardian's doing this long-term care pharmacy service at home that my insurance company has signed up for, or that Medicare has started to pay for. And the trust component starts to build for those pharmacies. So I think those are the things we think about. Obviously, we're going to talk a lot about that at our meeting, but that's sort of the thing that we all should be thinking about in this profession.
And there's multiple different revenue streams that we talked about, multiple different ways that pharmacies can think outside the four walls of a nursing home, even outside the restrictions and the control of the PBMs. And when you open up different revenue streams, all kind of in that same practice of providing healthcare to this patient. And by the way, we believe that we're the best at doing these certain areas here. And so I think that's a natural progression. That's going to happen. Some people take advantage of it, some people won't. But I think the next big thing that we really as an industry have to get our hands around is innovation, automation. We everybody throws around those key words like AI. Everybody's AI. Really, right now it just means Chat GPT is really the only AI that we're as a population that we're really exposed to. But
it's a tool.
Yeah, but there's so many things. The entire workflow process is automated, just not in pharmacy. The opportunity of customer service and relations and marketing and education is all automated now, but just not in pharmacy.
Yeah.
At the end of the day, I say this a lot, is we're in several ways, we're like 50 years behind other industries. We talked last time, like Toyota had just-in-time inventory using Six Sigma technique back in 1970, and none of our pharmacies, use anything like that. And so I think it's really important that pharmacies start learning and understanding the technologies and the innovations and the automations that are out on the market today. And then there are companies that are developing and moving these towards pharmacy. It might be not specifically designed for long-term care pharmacy, but for pharmacies. And it's a matter of, being like we were talking back in the 50s, being entrepreneurs, being out-of-the-box thinkers, and start saying, hey, there's a segment here, there's a need here. And I think there's a lot of untapped innovative resources, innovative softwares that pharmacies just aren't even aware of and not even trying to go after. And I think that's really the next big thing they need to concentrate on.
Yeah, it's definitely a holistic approach to this profession that we need to be thinking about.
Run it like a business, not dispense drugs.
Right, right. Not be over leveraged in any area. It can't be, heavy in any area. So we're live. So we're gonna have our producer speak. So producer Krista, who's been producing our podcasts.
Hello.
I think you have a different perspective as someone who will be attending annual meeting. What are you looking forward to from that perspective?
What am I looking forward to?
Yes.
In regards to annual meeting?
Yes.
Well, so I've actually been with ACP for about 5 years now, almost 5 years.
Seems like a long 5 years.
All right, Chad. And I started 2 weeks before annual meeting 5 years ago in 2018. And after annual meeting, I was like, oh, yeah, I'm definitely staying here. This is the best place. So I don't know. My favorite thing I'd have to say is just it's the chaos. I kind of love the chaos. I love the chaos because we as staff have to work together to make everything work. So when things are kind of crazy and everybody throws themselves in to contribute and, I don't know, solve said problem or literally get on their hands and knees and plug something in if it's not working, that's what I like about it, when we're all together and we all get to bond in those chaotic situations.
That's cool. I like that.
That was a very Miss America.
Well, I thought for sure you were going to say the Saturday night party. But
oh, well,
okay.
Duh.
I say just as long as you don't create the chaos, I think we'll be okay. So
I am the master of chaos.
Well, you did. I mean, you created you located the band. I mean, that's cool.
I did.
So the Saturday party is going to be exciting and fun.
Yes.
Kind of like we had it in Texas last year. So
well, but that social time is really key. And I mean, that's every conference has some kind of social areas of that kind of stuff. But the Saturday night party is fun because you guys make it fun. You create games. It's really interactive. I mean, everyone has a good time at that Saturday night party. So.
Well, it's a good, like, when we talk about all these deeper issues, like how to improve your revenue and fix your pharmacy and bill for services and save lives, like, we need that networking component.
Yeah.
We need to know that we're all in it together. We need to talk to each other about, like, what are you doing? Oh, you're doing that. Is it working? Yeah. Oh, maybe I should do that. Like, we need that piece of it. And then we need to probably have some time where we can blow off steam and have a good time.
That's what I was going to say.
There you go. But, like, and it always brings me back to relationships, because I think relationship is almost the basis of humanity. Let's be honest. We've allowed our healthcare system to move away from relationship at the center. And our association thrives simply because of relationship. But we need to help bring relationship back to healthcare. Like, if you don't know your pharmacist, you don't know your doctor, we've built systems to almost make that hard. Your doctor has to see 8 people every 20 minutes. You know, there's no time. She has no time for you.
And the patients had that with their local pharmacist, right?
They used to.
They call him Doc. You know, hey, there's my doc on the corner.
Everybody should watch the movie Doc Hollywood. They go back and watch that movie, because in that movie is a lot of answers to our problems.
Wow.
But we have to bring them back. Like, we have to bring that back.
Like the late 80s or something?
Yeah, it was late 80s. Michael J. Fox.
Yeah.
Well, I actually have a question for the two of you.
Okay.
In regards to annual meeting. What is your favorite memory of any annual meeting that you've ever been to with ASCP?
Wow. I'll let Tom answer first while I think.
Boy. I'm going to give the live PC version.
Oh, good.
Oh, boy.
Well, I believe that, gosh, there's so many, but we were up at the Gaylord here at National Harbor, and it was election night, and that was the Mitt Romney versus President Obama election, and we had a solution, a packaging device for pouch packaging that was going to allow us to do short cycle, and we had kind of gotten down that pathway. We had a nursing home, we had a beta going on, but it was really all based on healthcare reform. And if Mitt Romney would have won that election, they would have appealed and got rid of healthcare reform. And so short cycle goes away. And if Obama wins, then healthcare reform is going forward, and we're heading towards short cycle. And so we sat there with our finger on the button, and when it was clear that Obama was going to win, we're like, go ahead, start the beta tomorrow morning. We started producing and doing short cycle. And of course, that changed my life dramatically in many ways, very, very positively. But that was one of my favorite memories. It was the build up to that election. It was right there in D.C. It was a good time. I think Joe Theismann was one of the speakers at that.
Oh yeah,
that event.
yeah,
So
yeah.
I got to meet him in the lobby. I asked him how the leg was doing.
God, that's such a good answer. What am I going to come up with?
You didn't think of anything during that?
I would say, I'll go more recent and say that our San Diego meeting, because it was really, I mean, I could also say the last time we were in Orlando, we had 150 people there.
For COVID, yeah.
For COVID. And I was proud of the fact that we delivered that meeting when everybody else was canceling. I like the fact that ASCP can be ahead of the curve. I don't know what the right terminology is, but we can be independent, and we can do it our way.
Yeah.
Everybody else was canceling their meetings. We decided that there was a group of our members that wanted to meet and convene. We decided that we could do it safely with the Gaylord Palms, which is where we're going to be. And, you know, it had all the appeal of like a small state pharmacy meeting, because we had a room with just tables of vendors around for those that were bold enough or had rules enough that allowed them to be there.
I was there.
Right. And it was almost the intimate of the intimate.
Yeah.
Instead of it just being an intimate meeting like it is, you know, we have, 1,000 people at our annual meeting. This was 150. So it was even more intimate. And I think what really struck me was being on the other side from being a member to being an employee of ASCP, is seeing how impactful it was to the staff of that hotel. Like, I'm not a huge Orlando fan. I can say it out loud. I think we would have never gone back to Orlando had we not gone there in COVID year. And I interacted with the staff that were saying things like, we're so happy you're here. Nobody's coming out.
Yeah.
This is my job.
Yeah.
If we don't have meetings, I don't have work.
Yeah.
If I don't have work, I don't have money. Like the whole
hospitality
thing,
market was crushed during that time.
crushed.
Yeah.
So that really struck me, and I think Eric, it struck him as well. That made the negotiation to come back this year that much easier because they felt the same way about us. Thank you for coming. You didn't have to. You could easily have gotten out of your contract like everybody else did.
Yep.
And it was amazing. And we did a hybrid, and we had, as many people engaged, just in different ways. At that meeting. So I would say that's the coolest.
And when you're on these type of meetings, but you're doing it remotely in your office, man, you're not getting anything out of it.
No, you're not.
You're getting interrupted all day long and that kind of stuff. And it was a no-brainer for me. I'm like, no, if they'll do it, I'll go down there live. And yeah, it was really fun. It felt very intimate, and we basically did the same thing that we always do, just way less people.
Yeah.
There were no lines at the bathroom or at Starbucks.
And we were 6 feet apart. And I remember setting the chairs of the main hall were 6 feet apart. Yeah. Like it was very...
Which was all unnecessary, but...
Well, but at the time,
good practice.
It was just the sign of the times. But, I don't know. So when you're there this year and you're not thinking about the wait staff and the person that's handing you the beef skewer at the buffet, like those people are wonderful. They're wonderful people, and they were very appreciative. They're probably always appreciative, but because we didn't, engage them the same way because of that smaller meeting, we didn't really feel that. Yeah. So that's my favorite.
Certainly.
Favorite memory.
That was your favorite memory?
I think so. Well, that's my favorite memory I can do on a live podcast.
Yeah.
I'm pretty sure no one would say their favorite memory was
COVID.
a COVID meeting. But, that's why you're you.
That's why I'm me.
Also, you said something that you said, have it your way. I was like, all right, I didn't know ASCP was Burger King.
We're Burger King. Hey, can we get them to sponsor the podcast now that we did that?
Burger King?
Yeah, sure, right? Yeah, right.
No. Yeah, sure. A pharmacy organization. Let's get a fast food chain restaurant to sponsor an episode.
Oh my God, that reminds me of when CVS was selling alcohol and cigarettes. Like, that was a problem.
They still are selling alcohol, right?
I think they are selling alcohol still, but cigarettes, no. No, cigarettes, no. Then I shouldn't. I'm not making fun of CVS. That's not. All the big box pharmacies do that.
All the other pharmacies, though, are still selling cigarettes.
They could be too. Yeah, right.
Like
That's true.
Still doing that, but
so a fast food restaurant's fine.
Okay.
Everything in moderation.
I'll try my best.
That's right.
We'll see what happens.
You got to get all of the parts that you need. Whether it's dairy or vegetables or protein, it's all good.
It's all good.
Yeah, especially fast food.
Exactly.
French fries are a vegetable.
Exactly.
But I'm really looking forward to this year. I think there's more energy. There's more excitement. It's we're still just really coming out of COVID. Every conference has been less attended than it was pre-COVID, and so I'm looking forward to being a year removed or a little over a year removed, and I think it's going to be a great time. So
yeah. Do either of you know what your Halloween costume is going to be for the costume?
Well, I said last week I'm going as a pharmacist because that's a real stretch for me. But
we did a welding team exercise yesterday for ASCP, and maybe I'll go as a welder now that I'm skilled.
Well, for Halloween, I should probably dress up as a Cincinnati Bengal fan because that's scary, right?
Wow.
Dun, dun, dun.
That's bad.
That would be horrific, and that would be about the worst thing I could do.
You know what? You should dress up as Kenny Pickett, and I'll hold the ball as a Bengal. Oh, sorry.
Good stuff.
I'll be a defender. Yeah.
No. Well, I'll probably be on the ground or throwing interceptions. Right now, but due time.
That's good.
Yeah. We'll be like 8-1 by the time that the conference.
It's only 2 weeks. It's only 2 weeks. You mean when we play? Yeah. I don't know why we play at the end. like 3 weeks apart at the end. It's very strange.
It's just the easy part of our schedule. So
Yeah,
that's
I
how we're
guess.
doing it.
Well, our meeting is October 27th through 29th. You can still register. You should still register if you haven't registered. ASCP.com/annual. I would work my hotel rooms right now because we're getting close to being full if we're not full already. But if you run into that, send us a note and we'll see what we can do. They do, because there's multiple meetings in a Gaylord property, everybody has sort of you have to register your hotel by a certain date. But then after that date, if they're not using their rooms, then we can take them. So I know we're probably at capacity, but I know that we'll probably get some
More rooms if you need it.
at least I hope so. And I don't hear Eric coming up the steps to yell at me. So if he heard that, he might. But I think we'll be all right. So ASCP.com/annual for that. And we're going to do another live show next week. So tune back in, and we'll see you next week.
2 weeks.
In 2 weeks.
2 weeks. I'm told 2 weeks.
2 weeks.
Give or take.
I'm
Give or
told-
take a
wait,
week.
It's a live program in my earpiece. 2 weeks. 2 weeks.
Earpiece.
Thanks for joining, everybody. We'll see you next time.
Thank you.